think you need any of this. It's there. Okay, are we ready to go? Thumbs up in the back. All right, good morning. I'm Dr. Stephen Little. Welcome to Houston Methodist DeBakey Grand Rounds. Today we have a special treat in our speaker. Before I jump to that, let me just deal with the housekeeping issues that are typical of this. So we'll have time at the end for some questions. There are microphones. Please use those so they get transmitted into the recording and to the online folks as well. We'll be broadcasting live via our Vimeo and YouTube. Recordings will be available. Obviously, if you're not here and you're watching, you'll know that. Okay, if you'd like to submit a question, you text that to the word DeBakey, and the phone number or the number to use is 37607. A couple of reminders about upcoming events. The Re-Evolution Summit is on March 26th. ACHD Fellows in Training Summit is on April the 10th. And CVD Prevention Symposium is on April the 11th. So lots of Methodist activity coming up. Okay, so we have a special treat. Our own Dr. Sachin Goel is going to give us a cardiovascular grand rounds this morning on a topic that's very near and dear to his heart, aortic regurgitation and the applications of TAVR, which are very new and incredibly timely in terms of events that happened just a couple of days ago. So this is a remarkably fortuitous timing for this grand rounds. Dr. Goel is an associate professor of medicine at Cornell. He's been with us now for 6 years. And I've got to say, I work with him very closely, and he's created an incredible transformation of our structural program, not just clinical excellence and technical excellence, but how he's sort of brought together postdocs and research and publications and abstracts, and it's really sort of energized and put turbo on the entire research portfolio of the structural team, and that's entirely Dr. Goel's sweat equity, and we're grateful for it. So without further ado, Dr. Goel, come up and tell us about your passions.
Thank you very much, Steve, for such a kind introduction. I'm just fortunate to be working in a place like this with a team that we have. So we'll talk about TAVR for pure aortic regurgitation, expanding the frontier. Here are my disclosures. So the outline of this talk, there's quite a bit to talk about. Hopefully we can get through this in an hour, but we'll talk briefly about the epidemiology of aortic regurgitation, the risk of mortality in untreated aortic regurgitation. Important point is the under-treatment and under-recognition of aortic regurgitation. And then, of course, the need for a different approach for TAVR in aortic regurgitation compared to aortic stenosis. We'll share a couple of examples of off-label TAVR, meaning TAVR performed with AS devices. And then the focus is dedicated devices such as the Yenna valve and the J valve. And I'll share some of the data from the trials looking at these two devices. So before we get into the nitty-gritty, I always like to think of the history of any particular disease. And there is more written about aortic regurgitation than perhaps any other pathology in cardiovascular medicine, dating back to almost 300 plus years ago. The first description was by William Cowper, who described a pathological specimen of the heart as being larger than an ox, and coined the term cor bovinum that we use for aortic regurgitation and some other pathologies, including dilated cardiomyopathy. And then during the same period, the first description of a collapsing pulse was found in a patient, and it was hypothesized that the aorta sent back blood into the left ventricle as part of this valvular pathology. And then, of course, autopsies started confirming the pathology, particularly starting with syphilitic aortic aneurysm and aortic regurgitation. For those of who still use a stethoscope and you do physical examination, there are more physical signs and associated with aortic regurgitation compared to any other, again, pathology in cardiovascular medicine. And, I think of my medical school days, which was where exams used to be not just questions, but, actually seeing patients in the wards and making a diagnosis based on physical examination. And all these physical exam findings were still important and are still important in today's day and age. Anyway, moving forward, as you all know, valvular heart disease is significantly underdiagnosed and has become more and more common with the aging population. As you can see, as patients live longer, we're seeing more and more patients with moderate to severe valvular heart disease. This is almost a decade ago now. This is a survey from Europe. Back in 2016, there were about 1.6 million patients with moderate or severe valvular heart disease. The projection is by 2043, there will be 3 million people, double that number, patients with moderate to severe valvular heart disease. These are data from Minneapolis, more contemporary data, prospective cohort of over 900 patients with valvular heart disease, without valvular heart disease, who received an echocardiogram over a period of 2 years. Median age was 74, and significant valvular heart disease was present in 16% of the patients. And you can see predominantly these were valvular regurgitant lesions as opposed to stenotic lesions. We always like to think of aortic stenosis as the most common valve disease, but perhaps it may not be the case. Similar data from Europe, over 2,500 patients, more than 65 years of age. Significant valvular disease was found in 6.4% patients. 15% of these patients actually had aortic regurgitation, and almost 80% had concomitant valvular disease associated with aortic regurgitation. So it's pretty common. That's the main message. Moving on, the pathophysiology of chronic severe aortic regurgitation, you all know as cardiologists or cardiology trainees. This is a valvular heart disease associated with volume and pressure overload on the left ventricle. Patients can remain compensated for a very long time with preserved ejection fraction when they develop eccentric and concentric hypertrophy and LV enlargement. And then this progressive LV dilatation eventually leads to decompensated severe AR, elevated EDP, and LV systolic dysfunction, which is often the late stages when we see these patients. But there is often a prolonged phase of asymptomatic phase where all these changes, remodeling is occurring in the left ventricle. The mortality of severe symptomatic aortic regurgitation, these are data from back in the 90s. When you look at this, patients who have, so this is a highly morbid disease. 70% of the patients died at 5 years, particularly if they had NYHA class 3 or 4 symptoms. Even if they had NYHA class 2 symptoms, their mortality was significantly higher than patients who had no symptoms. So it's very important to realize that substantial number of patients will die without treatment. These are some more contemporary data from the United States. Important to note that the rates of evaluation by a heart team surprisingly are low for severe aortic regurgitation. Less than 50% of the patients with significant aortic regurgitation undergo an evaluation by a heart team. Heart team meaning cardiologist and cardiac surgeon or interventional cardiologist. Mortality among patients, again, in the same subset, this is a multi-center study, was significant in patients with significant aortic regurgitation, 20% at 2 years. These are more contemporary data. So when do these patients undergo an intervention? What do the guidelines tell us? So these are the ACC/AHA valve guidelines from 5 years ago now. So if you have patients who have severe aortic regurgitation and they're symptomatic, then of course the recommendation is AVR. But oftentimes these patients are not symptomatic, as we heard. These patients can be asymptomatic for a long period of time as their LV undergoes enlargement, dilatation, and remodeling changes. So what do the guidelines state? So in asymptomatic patients or stage C, if you have an ejection fraction of 55% or less, then it's a class 1 indication. If they're obviously undergoing cardiac surgery for some other reasons, then it's a class 1 indication. On the other hand, if their ejection fraction is still greater than 55%, systolic dimension is more than 50, and indexed LV and systolic dimension is greater than 25, then it's a 2A indication. And then if you have a progressive decline in EF or increase in LV-EDD more than 65 millimeters on at least 3 studies, then the guidelines give this a class 2B recommendation. So these guidelines are rather conservative. In other words, should we wait for symptoms? Should we wait for LV dysfunction to occur? Or should we wait for severe LV remodeling before we intervene on these patients? That becomes the question. So these have been looked at in the last 7-8 years. So when you look at patients who had NYHA class 1 versus progressive symptoms, so these are patients undergoing AVR. Patients who had class 3 or 4 symptoms clearly had worse outcomes compared to patients who had minimal or no symptoms. So again, the guidelines say that asymptomatic patients you can wait, but perhaps that may not be the right thing to do. Waiting for the EF to drop, the guidelines have a cutoff of 55%. But you can see from this contemporary paper from the Mayo Clinic, the mortality risk starts going up once your ejection fraction falls below 60%. So perhaps the 55% cutoff in the guidelines is too conservative. Wait for the end systolic dimension to be more than 25. This is what the guidelines state. But again, similar data from Mayo Clinic shows that this mortality risk starts going up once your ventricle, the left ventricular end systolic dimension, indexed LVESD, is more than 20. So there is growing evidence that some of the markers of poor outcomes, the cutoffs, are much lower than our current guidelines state. We also know that there is clear benefit of surgical aortic valve replacement in severe aortic patients. This was a large database published by a study published by Vinu Torani 5 years ago, on more than 4,000 patients with severe symptomatic AR between 2008 and 2016. The mortality was 9% at 1 year in patients undergoing AVR, 24% if they had untreated severe AR. So the mortality obviously was significantly higher. But on the right side, you can see that no matter what their ejection fraction is, they have a significant survival benefit if they actually undergo treatment for severe aortic regurgitation, whether they have preserved ejection fraction or whether they have low ejection fraction. Unfortunately, only about 25% or 1 in 4 patients with symptomatic severe AR had AVR within 1 year of diagnosis. That is the biggest problem. And then what about patients who do not have surgery or are not surgical candidates? Again, very small percentage of these patients have surgery. 3/4 of them do not have any surgery or any interventions. With medical management, we've seen that their mortality at 1 year is 25%. With SAVR, it's lower. With TAVR, which is off-label TAVR, I'm talking about off-label TAVR here. Off-label means TAVR performed with devices that are used for aortic stenosis, such as the SAPIEN valve or the Evolute valve. They have very high mortality, and we'll talk about some of the data with off-label TAVR. So this slide is from Rick Nishimura from JACC Imaging a few years ago, and we all realize that symptoms occur late in the course of disease, and it can be unreliable to define thresholds of intervention based on symptoms. Symptoms often occur when the LV is already enlarged, there's already LV dysfunction, and that unfortunately may not be, for some patients it may be too late, or the risks of intervention may be much higher, and the optimal timing of surgery may be a little bit earlier in the course of the disease. The other issue, again, this is not an imaging talk, but the other issue pertains to the accuracy or the diagnosis of aortic regurgitation, which can be challenging. At least I find aortic regurgitation one of the most challenging valvular lesions to quantify. These are data from Dr. Malafchi and Dr. Deepan Shah from our own institution, and these data are widely cited. When you look at echo versus MRI, the agreement is 40% or fair, meaning there is a 50% chance that the echo and the MRI will be concordant, 50% chance that they may not be. This data is looking better based on some of the more recent analyses. The other issue is these thresholds for MRI for the severe aortic regurgitation differ between echo and MRI. For example, for regurgitant volume for MRI is 47 ml and 43%, as opposed to 60 mL and 50% for echocardiography. And again, there is strong data showing that these thresholds are important when you look at the poor outcomes. Again, from the same group, from our group, from Dr. Malafji and Dr. Shah's group, additional prognostic value of CMR-derived volumetric data has become very important. It has become recognized that the end systolic volumes are more prognostic than ventricular diameters, which the guidelines currently use. And this has been replicated by other centers, including Minneapolis, Oxford, and other places. And these have started to become incorporated, as you will see in the trials for aortic regurgitation, and also the European guidelines. These are the 2025 update of the European guidelines, where you can see some of these numbers, the left ventricular end systolic volume of 45 mils per meter square, and then they also use a lower diameter or LVESD cutoff of 22 as opposed to 25 based on the data that I shared in the past few slides. So I think the US guidelines are a little behind, but once the updated version of the guidelines comes out, they will start to incorporate some of these important data over the last 7 or 8 years. So the main part of the talk is TAVR for aortic regurgitation. The transcatheter solution obviously is an important option for these patients who may be otherwise high risk or may be presenting late with ventricular enlargement, ventricular dysfunction, which is why 3/4 of these patients do not undergo surgery. But fundamentally, TAVR for aortic regurgitation is different from TAVR for aortic stenosis. And obviously, the reason for that is the pathology is different. In aortic stenosis, you have a lot of plaque, a lot of calcium, which allows you to anchor the valve. In contrast, pure aortic regurgitation, there is little to no calcium. So the anchoring of the valve can be a problem. There is higher risk of embolization and migration, as you will see in the subsequent slides. There may be issues with sealing of the valves that are designed for aortic stenosis. And then, of course, risk of residual regurgitation. There is a long history of off-label TAVR for aortic regurgitation with devices that are used for aortic stenosis, such as the Sapien generation of valves, the Evolute valves, and a whole bunch of other valves. And again, the message is that there is insufficient anchoring, there is risk of dislocation or embolization of the valve, there is risk of residual regurgitation due to incomplete sealing, risk of these patients often will have concomitant aortic dilatation and very large annuli. So that is the challenge with aortic regurgitation in contrast to aortic stenosis. So a couple of slides on some large registries looking at the outcomes of TAVR for aortic regurgitation with the conventional self and balloon expandable valves that are designed for aortic stenosis. So this is a multi-center registry from Europe, over 200 patients, and they looked at the Evolute category of the Evolute generation of self-expandable valves and the Sapien and the MyValve. MyValve is like the Sapien. It's not available in the United States, mainly in Europe and Asia. And when you looked at the short-term performance, there was no difference between the self and the balloon expandable platform. However, the risk of mortality was high, 5%. Risk of needing a second valve due to valve migration or embolization was 10%. Risk of moderate or greater AR was almost 10%. And technical success and device success was significantly lower compared to contemporary TAVR. This is a meta-analysis that we published last year with Sahar Samimi. She was one of our research fellows, and she's currently a second-year resident next door at Baylor. So she compiled 34 studies looking at over 2,000 patients, over 1,000 with dedicated devices such as the Yenna valve and the J valve, and over 900 patients with off-label devices. And we compared the outcomes for TAVR with aortic regurgitation with dedicated versus off-label devices. And the device success was significantly higher with TAVR with dedicated devices. There was similar risk of stroke and vascular complications. Importantly, risk of mortality at 1 year was 6% with dedicated devices versus 24% with TAVR performed with devices for aortic stenosis. And you can see in this central illustration, again, the risk of moderate or greater aortic regurgitation was significantly higher, risk of valve embolization migration significantly higher, risk of reintervention and second valve placement significantly higher, and so was the risk of pacemaker. So all outcomes were significantly worse when TAVR was performed with off-label devices or devices used for aortic stenosis in this patient population with aortic regurgitation. So this basically tells us that there is a huge unmet need for dedicated devices for TAVR for aortic regurgitation. So what do the guidelines say? Again, on the left side is the American guidelines. The US guidelines, they gave a category 3, or in patients with severe isolated AR who have indications for SAVR and are candidates for surgery, TAVI should not be performed, or there is a signal of harm based on obviously all this data. The European guidelines on the right side state that TAVI may be considered for treatment of severe AR in symptomatic patients ineligible for surgery according to the heart team if anatomy is suitable. So that's a very broad statement. If anatomy is suitable, what devices and so on. So here is an example of off-label TAVR or TAVR performed with a device that is routinely used for aortic stenosis in a patient with aortic regurgitation. Clearly you can see on the echo there is severe aortic regurgitation. And here is the Evolute valve. This is where the valve should have been implanted, but the valve is clearly migrated ventricular and is very deep. So this was not uncommon when we were doing some off-label TAVRs for aortic regurgitation. So you can see the treatment here is, you can see these two dark lines. This is basically a snare device pulling the Evolute out of the LV and holding it as the Sapien valve is brought around the arch into the Evolute valve, and then a Sapien valve is deployed to fix this problem. Ultimately, the patient had a good outcome, But you can see how this could be a problem if this cannot be achieved, or if the valve migrates into the ventricle, or if there's other complications with this off-label approach. So this brings us to the dedicated devices. There are two devices that I'm going to talk about. One is the Yenna valve, and the other is the J valve. In terms of data, we know a lot more about Yenna valve compared to the J valve. Coincidentally, the Yenna valve was approved by the FDA yesterday, so March 18. So what is the Yenna valve? Yenna valve is a porcine pericardial tissue valve, which is mounted inside a nitinol frame. It has large open cell design. The unique feature is this locator technology, which there are 3 locators, and this allow the valve to be aligned with the native cusps and to anchor into the native cusps without relying on presence of calcium as with the aortic stenosis devices. And we'll show you a case example of how this works. This comes in 3 sizes, 23, 25, and 27, and we can treat annular range from 66 to almost 90 with this device. And that is important because a lot of the patients with aortic regurgitation have large annuli. So that's where the J valve is important, as we'll talk about. So the steps in the deployment of the Yenna valve trilogy system is to align these 3 locators with the native cusps, then to position and anchor the clips into the native leaflets, and then deploy the valve. So here's a quick case of a patient that we did not too long ago, a 75-year-old gentleman with liver cirrhosis, prior liver transplant, coronary disease, multiple stents, atrial arrhythmias, and ablation history, and basically severe aortic regurgitation and worsening symptoms. So the patient's anatomy was suitable for Yenna valve. In the interest of time, I skipped the CT workup. But the first step is to do a aortic root angiogram in the coplanar view. Coplanar as in the 3 cusps are at the same plane. The next step is to advance. So this has a long sheath which extends all the way into the ascending aorta. The device is then advanced through the sheath over a safari wire that is placed in the left ventricle. We check the position of these 3 locators. Those 3 dark dots are basically the 3 locators. And then the valve is then advanced through this sheath into the ascending aorta, and this sheath is then retracted back into the proximal descending aorta beyond the subclavian artery. The next step is then to advance the controller system and to advance the device into the native annulus. The next step is then to sweep from LAO to RAO to check the position of these locators. So when we go from LAO to RAO, if we see 2 locators on the left side of the screen, that is incorrect. We want to see these 2 locators on the right side of the screen, where it would be between the non in the left and the non in the right, respectively. So then we are able to rotate the device while the device is still in the, at the level of the annulus or above the annulus, and then we sweep from LAO to RAO, and on the right side you can see the 2 locators are now on the right side of the screen compared to the left side. So this locator here is in the non-coronary cusp, and these 2 are in the right and the left respectively. So this is how this device is positioned, and then once that is performed, we check the position of the locator in each of the coronary cusp with a simple coronary catheter. Here is the locator at the bottom of the non-coronary cusp. We swing over and check the position of the right locator, and then we use a Amplatz. Sometimes we can do it with the multipurpose, but sometimes we have to use an Amplatz catheter to clearly visualize the position of the left locator in the left cusp, and you can clearly see the left main there. So once we've verified that all these locators are in appropriate positions, the valve is then deployed. And the next step is then to carefully retrieve the nose cone. Again, remember, there's no calcium, there is no plaque, there's, unlike aortic stenosis, this valve is anchored. Again, this valve is anchored with the help of these locators and the radial strength of the device, but we have to be very careful in retrieving the nose cone so that we don't inadvertently yank the valve out of position and cause embolization. And thankfully, we have not seen that. And here's the final angiogram demonstrating excellent result, trace aortic regurgitation, and normal-looking ascending aorta arch and descending aorta without any aortic injury. On follow-up, this patient had significant clinical improvement, and there is trace residual aortic regurgitation and is now asymptomatic. And we have very good experience thus far in our center. And of course, the Align AR study is the largest study in the field of aortic regurgitation and TAVR. which was the multi-center, non-blinded, single-arm study evaluating symptomatic 3+ or greater AR patients at high risk for SAVR who underwent TAVR with this Trilogy system. And these patients will be followed out closely to 5 years. There was a 30-day primary safety endpoint and a 1-year primary efficacy endpoint, which is listed here. The safety endpoint was technical success with mean gradient less than 20 and reduction of AR by more than 1 grade. And the 1-year primary efficacy endpoint was major adverse events such as death, MI, and stroke, and cardiac surgery. And this is the flow. The original paper had about 200 patients. This was published in Lancet, but the study, the continued access program, continued up until yesterday when the FDA approved it, but now we have data on 700 patients over the course of the past few years. So this is the largest data set looking at TAVR for aortic regurgitation. So the characteristics of these patients, these patients are, late 70s, mean age is 79. STS prom is about 4%. About half are female, and vast majority of them are in NYHA class 3 or 4 heart failure with the routine usual comorbidities as you can see on the slide. 15% of these patients had baseline or pre-existing pacemakers, but a substantial proportion had pre-existing conduction abnormalities, as you can see. So typical TAVR population, when you look at, if you were to look at a contemporary AS population, for instance, the AR severity was severe in about 44% patients, and about 55% of patients it was categorized at moderate to severe. The ejection fraction was not completely normal. The mean EF was 54%, and the annulus perimeter was about 80. About 40% of these patients had holodiastolic flow reversal and some of the other parameters that you look on echocardiography. Technical success during the procedure was 95%. Procedural death, 0%. Surgery or reintervention related to the device or access site, again, low at 3.7%. Device success at 30 days, 97%, again, 0% procedural death. Prosthesis mismatch, 0. Gradient less than 20, achieved in 100% of the patients. Moderate to severe residual AR, 0.5%. So very safe and very effective. When you look at the primary safety endpoint, again, all-cause mortality at 30 days was 1.6%, with a cardiovascular mortality rate of 1.2%. Remember, these are higher risk patients that are not otherwise felt to be surgical candidates with a STS predicted risk of mortality of 4%. So substantially lower actual mortality when compared to predicted risk of mortality. Risk of stroke, 1.7%, with disabling stroke of 0.6%. Again, these data are comparable to TAVR for aortic stenosis. Life-threatening bleeding, 2.7%. Pacemaker was 21%, and we'll talk more about the pacemaker rates. Patients, substantially higher risk of pacemakers, at least early on in the study. The risk of moderate or greater residual regurgitation, 0.5%. So again, very good data, very safe, very effective. The valve orifice area, valve performance is excellent. You can see some of the largest orifice areas for transcatheter valves with the Yenna valve. When just to give you perspective, when you look at SAPIEN or Evolute, typically the effective orifice area is in the range of 1.6 to 2.0. But here you see an effective orifice area of 2.8, 2.7, with not only single-digit gradients, but gradients less than 5 millimeters of mercury. And then out to 2 years follow-up, vast majority of these patients have none or trace residual aortic regurgitation. The pacemaker. So the pacemaker was interesting. 20% pacemaker obviously, sounds high. 1 in 5 patients end up with a permanent pacemaker. But when you look at the experience, as the experience, in these 700 patients progressed over the course of time, I draw your attention to these bar graphs here. When they divided the experience into tertiles of first, second, and third tertiles, the pacemaker rates decreased from 25% in the early experience to 15% in the last tertile, in the latest experience. And mind you, the risk of pacemaker with TAVR for aortic stenosis, and for example, the low-risk Evolute trial was about 15 or 16%. So we're now able to achieve similar pacemaker rates compared to the early experience with TAVR for aortic stenosis. And when you looked at the data for multivariable predictors of pacemaker after Yenna valve, patients obviously with pre-existing right bundle branch block were at significantly higher risk of needing a pacemaker. And then patients who needed a large valve compared to a medium or small valve were at increased risk by virtue of large size and oversizing causing more pressure or compression on the conduction system. In aortic stenosis, there is a lot of calcium, which bears the brunt of the pressure from the valve, whereas in aortic regurgitation, there's no calcium, there's no plaque. The radial force of the valve is directly transmitted to the conduction system, which is nearby. So these were found to be the predictors. And over time, obviously, the operators and the cardiologists and interventional cardiologists and surgeons doing this procedure realized this, and the techniques also evolved. We're not deploying these valves very deep as we were doing 5-6 years ago, and then the oversizing is less. And as a result of these, we are seeing a reduction in the risk of need for pacemaker with the Yenna valve. So again, FDA has approved this device for patients with symptomatic severe aortic regurgitation who are considered high risk for surgery. This approval came yesterday, and this is great news, I think, for patients with aortic regurgitation. The next trial for the Yenna valve is the ARTIST trial, which we are also part of. This is a trial that is randomizing patients with severe aortic regurgitation to surgery, following sort of the same pathway as aortic stenosis did. Aortic stenosis, as you recall, was studied in high-risk patients, randomized to surgery, then intermediate risk, randomized to surgery, and then low risk, randomized to surgery. So Yenna valve is obviously going through the similar pathway where it's already been studied in high risk, now approved. And this is the next sort of frontier where it's being randomized to surgery in patients who are otherwise surgical candidates, low risk or intermediate. So about 1,000 patients will be randomized 1-to-1, and it's a non-inferiority design at 12 months. The outcomes will be death, stroke, urgent rehospitalization, and these patients will be followed out to 10 years, given that they are obviously lower risk and younger patients. So again, this is a prospective controlled multi-center study, randomized 1-to-1, over 1,000 patients, over 60 sites in the US, 30 OUS sites. Primary endpoint, as we talked about, death, stroke, unplanned rehospitalization, and a whole host of secondary endpoints, as you might expect for a trial like this. The key inclusion criteria, this is important. The inclusion criteria is Class 1 or Class 2 indication for AVR, according to ACC, AHA, or ESC guidelines, meaning these patients don't have to be symptomatic. These patients could be asymptomatic, but they have some indication based on ventricular remodeling. And it is refreshing to see some of these markers or things, the cutoffs that we discussed in terms of the ventricular diameters, ventricular volumes derived by MRI being incorporated into the trial. So this is a very contemporary trial, obviously, based on the contemporary data over the last 7 or 8 years, looking at LV damage or LV remodeling as an indication. So this will give us a lot of data on how these patients do when they are asymptomatic, for example, and they have LV enlargement and undergo an intervention. So they obviously have to be candidates for both intervention, TAVR with Yenna valve, or surgery. These are for patients who are being contemplated for aortic valve replacement, not aortic valve repair. These patients, are not those that are going to have large aortas and will have concomitant, for example, ascending aorta replacement. So pure AVR surgical versus TAVR. So that is the trial. So we're actually actively enrolling in this important trial. This is going to be very exciting over the next few years. Again, exclusion criteria are standard exclusion that you would expect if they have 2+ or less AR, if they are going to have aortic surgery concomitantly or aortic valve repair is the plan, or if they have significant concomitant mitral tricuspid disease, very low EF, very poor kidney function, and so on and so forth. So switching gears, the other dedicated device system that we have is the J-valve system. The J-valve is a bovine pericardial valve with a nitinol frame and anchor rings. In contrast to the Yenna valve, which has these locators, it has these anchor rings with the similar idea that each of these anchor rings anchors in each of the native cusps, and it's a self-expandable valve, and it comes in 5 different sizes. I'll draw your attention to the bottom 2 rows here. This provides the ability to treat patients with very large annuli. The Yenna valve, currently, the current form of Yenna valve, we can treat up to annular perimeters of 90, but this allows us to treat patients with annular perimeters as large as 104. And substantial proportion of patients will have large annuli with aortic regurgitation. So we were part of the J-valve EFS. The data obviously is less with Yenna valve with J-valve in the United States compared to OUS, for instance, in China, which has the largest experience with the J-valve so far. But the J-valve EFS was performed and published last year. 25 patients with severe aortic regurgitation were studied, and again, standard inclusion-exclusion criteria. In the interest of time, I won't go through all of these. They had to be candidates for this. In one patient, the procedure was aborted due to a vascular complication, meaning the valve was not implanted. In one patient, there was conversion to surgery because of an issue with valve release, and there was one death, which was neither procedure-related or cardiovascular-related. The death was actually because of foreign body asphyxiation, somebody who was eating a fish. Anyway, but it counts as a mortality, and that's the nature of the trial. So 30-day follow-up was available in 22 patients. As you can see, high-risk patients, mean age is 80, STS promise 5%. They're all symptomatic, conduction defect in significant proportion of patients, similar to the Yenna valve study, 44 and 56% with severe or moderate to severe AR. Important feature is the aortic root angulation more than 60 degrees. It was present in about a quarter of the patients, and about 40% of these patients had perimeter more than 90. So these two characteristics are perhaps less favorable for the Yenna valve, but with the J valve, we are able to treat these patients with anatomy that may not be suitable for the Yenna valve. The valves 31 and 34, the large valve was used in almost 60% of these patients, and conversion to surgery, as I talked about, was required in one patient, vascular intervention in one patient, procedural mortality 0, device migration embolization 0, bleeding complication very low, and again, no valve migration. All-cause death was seen in 2 patients, 0 cardiovascular mortality, 1 non-cardiovascular mortality. 1 patient had a stroke out to 30 days, 2 patients or 8% need for pacemaker, and very low rates of other complications as you see listed here. Again, small trial, but important data with this device. The valve performance, again, was excellent. When you look at the gradients, they are single-digit, 5 millimeter mean gradient, effective orifice area, similar to the Yenna valve, 2.7, 2.8 effective orifice area, much larger than what we see with valves for AS. Again, excellent results with regards to residual AR, vast majority, 95, 96% patients with none or trace residual regurgitation. Good reduction in LV diastolic and systolic volumes, ventricular remodeling, and improvement in quality of life, and NYHA class over the course of 30 days, and now to 1 year. So again, there was 0% hospital mortality and CV mortality, low incidence of pacemakers, low incidence of residual regurgitation, and good LV remodeling and favorable hemodynamics with the J valve in this EFS study. The next step with the J valve, which we are also part of, is the Journey study. J valve is now acquired by Edwards Life Sciences, as you may know. So the Journey trial is the next big trial, which is a pivotal IDE study looking at the J valve in high surgical risk patients. Almost 200 patients, 42 sites globally will be studied with safety co-primary endpoint and efficacy endpoint. And these patients will be followed out annually for up to 5 years. So again, these are the study details. This is an important study. The key inclusion, again, is patients who are symptomatic or they have evidence of LV remodeling, as we saw in the ARTIST study with the Yenna valve, incorporating the MRI characteristics of left ventricular volumes, as we talked about. Obviously, these patients are high risk for surgery, and they have to be suitable for the TAVR with the J valve. The exclusion criteria are pretty standard, as you can imagine: severe concomitant mitral or tricuspid valve disease, very low EF, poor kidney function, and other standard exclusion criteria. And again, the valve, as we discussed, provides the ability to treat patients with very large annuli with perimeter more than 90, which is a substantial proportion of patients with aortic regurgitation. So here's a quick example of patient treated with the J valve. This is an 86-year-old patient with STS score of 7% with 3+ aortic regurgitation with good anatomy. And this is how the device looks. So the device has the sheath. The device is advanced over the safari wire. The anchors are then exposed. You'll see in a few seconds. The anchors are then advanced to the level of the aortic annulus. This is again a self-expandable valve. There is no balloon here. And the valve, once you confirm the location of those anchors with angiography and echo, then the valve is released, as you can see here. And this is a typical example of what the echo would look like after the deployment of this valve. And then the nose cone is again carefully retrieved, similar to the Yenna valve. So shifting gears, the last part of the talk is LVAD-associated aortic regurgitation. This is an important subset of patients. Again, our heart failure colleagues see these patients. This is a patient we took care of about a year and a half, maybe 2 years ago. A nice 78-year-old lady with cardiomyopathy and LVAD, which she had had for about 7 years, and presented with worsening symptoms despite no issues with the LVAD, just worsening symptoms, reduction in quality of life, NYHA3 symptoms. And sure enough, on the echo, we found significant aortic regurgitation. It's important to note, I think the heart failure colleagues appreciate it very well, but the criteria for severe aortic regurgitation are different for when you look at LVAD and non-LVAD patients. For instance, in a patient with an LVAD, even a moderate continuous aortic regurgitation is significant and can be categorized as significant and can be included for some of these studies that we have for LVAD, for TAVR and LVAD. So this patient clearly had significant aortic regurgitation. You can see the inflow cannula there, and she was very symptomatic without any other obvious explanations. And her anatomy, thankfully, was good for the Yenna valve, and you can see the implantation of the Yenna valve and post-Yenna valve root angiogram showing trivial residual aortic regurgitation. She almost instantaneously, felt better. Her symptoms are resolved. She, returned to her pre-TAVR or pre-AR functional quality of life and is still doing well from what I can tell. This is the echo post-Yenna valve implantation, so trace residual AR. So this is a good option for patients with LVAD who have significant aortic regurgitation and are developing symptoms. So we do have the Yenna LVAD registry, which is now studying this systematically in a multi-center fashion. In addition, we also have a JVAD registry, which is looking at J valve in a VAD population. So two different registries, but good option for VAD patients that have developed aortic regurgitation. So in conclusion, as you saw, off-label TAVR for aortic regurgitation is associated with high risk of complications. There's clearly an unmet need for a dedicated device, and we have two such devices now, the Yenna valve and the J valve. The ALIGN-AR studies shows a very encouraging data for the Yenna valve trilogy system, and this has now led to the FDA approval for high surgical risk patients. Enrollment is continuing in the ARTIST randomized trial, which is randomizing low or intermediate surgical risk patients to SAVR versus Yenna valve trilogy. The J valve obviously is an additional tool, allows us to treat patients with larger annuli that the Yenna valve currently cannot. And the JOURNEY trial is the pivotal trial enrolling high surgical risk patients. And again, we have options for treating patients with LVAD with significant aortic regurgitation with both Yenna valve and J valve. With that, I'd like to thank you for your attention and happy to answer any questions.
All right, Sachin, I'll go with the first question. So, masterful. I know you put this talk together quite quickly. I think your invite was quite late to this, so fabulous work. Question for you about the initial few points you made about AR quantitation. And I know Dr. Shah, Dr. Malafji, a small army of our imaging fellows and postdocs have done tremendous work in sort of redefining the thresholds for prognosis and ultimately suggesting that what the numbers we use in echo are probably not the numbers we should be using for chronic AR, indexed LV and such. But one of the things we still don't do very well is index the regurgitant flow to the ventricle that's receiving the flow. Right. So if you imagine 60 mils of AR into a 40-year-old with a bicuspid valve and otherwise normal LV is quite different than 60 mils into a 90-year-old who has a stiff, non-compliant, relatively small LV. So same volume, but a completely different prognosis. What have you seen around that? Because I think we're still very rudimentary in how we quantify volume without quantifying risk.
Yeah, that's a great question, Steve. Completely agree with you. These thresholds are, thresholds, and may not be applicable to all the patients. As you pointed out, the ventricular size, the age of the patient, gender. There is increasing recognition that it may not be the same for men versus women. So there are all these, and I know Dr. Malafchi and Dr. Shah are here. They can probably attest to this better than I can. But you're absolutely right. These thresholds are, we are learning clearly more about the pathophysiology and defining these thresholds with the help of the MRI. It's good to see that these cutoffs are being incorporated in, for example, the European guidelines and the newer trials, the ARTIST and the JOURNEY trials. But there's still a lot that we don't know. I think a lot of this is based on the cardiac damage premise when we see the ventricular enlargement, the ventricular volumes. But you're absolutely right. I'm curious to see what, Dr. Shah and Dr. Malafchi, who have done such seminal work on this field, have to add.
Is this on? Yeah. So first, Sachin, outstanding presentation. I always enjoy hearing you speak, and I always enjoy seeing the images of the interventional procedures. So, I mean, to kind of address that question, I think one of the things I think we're realizing is that aortic regurgitation may be not one single disease, or one single patient group, rather a heterogeneous group of patients. And a lot of the early studies, if you look at it, those are patients in their 30s and 40s. Those are bicuspid valves, many times endocarditis patients. That ventricle is very different than the type of patients you're seeing referred for these transcatheter procedures, which are oftentimes in their 70s and 80s, a lot of other comorbidities. I think one of the things that's helpful to kind of the concept Steve's talking about, which is to index the volume to the ventricle that's receiving it, is when we do regurgitant fraction, because we actually then are dividing the regurgitant volume by what the flow of the ventricle is putting out. So I think that's helpful. And another thing that hasn't been looked at that much, but I think is useful, is to kind of say, what is the net output of this ventricle going forward to the body? Like the systemic stroke volume, which I think also can give you, in essence, it kind of corrects for all these other things. It says, in the end, what's happening as far as what's getting to the patient, what's getting to the rest of the body. So I think that's helpful. So Sachin, I mean, a question for you, in today's world, when you're working up these patients, tell me, what are you looking at? I mean, obviously, I think you're taking all imaging that you can get, but how do you put it together? And I think the big question also is, especially in a lot of the elderly patients, how are you kind of teasing out if you think the symptoms are due to the valve disease versus if you think the symptoms are due to kind of underlying HFpEF physiology or something else that the patient may have?
Yeah, these are great questions, Deepan. Thanks. So, when we work up these patients, we, as we rely on not just echo, but echo and MRI. If they cannot have an MRI, we'll most certainly do the TEE. There's a lot of value and a lot of new literature looking at CT and looking at the orifice area or the regurgitant orifice area on the CT. So there is, the message is, look for more significant aortic regurgitation, which can sometimes be underappreciated by echo. So it's often multimodality imaging, echo plus MRI or echo plus CT. Almost all patients will get a CT if they're being evaluated for TAVR. Teasing out the symptoms is challenging. Usually by the time we see these patients, they've all these are, as you said, older patients in their late 70s and 80s. They've had aortic regurgitation for a long time. So most of these patients will have evidence of, cardiac enlargement, LV dysfunction, big ventricles, big volumes, and most of them are symptomatic. We rarely see patients who are, who have a preserved LV function, have normal LV size, and they have significant aortic regurgitation, and we're trying to figure out, whether this is from HFpEF or AR. We do see that population in AS, though. We were part of the EXPAND TAVR trial, which was TAVR versus medical therapy for moderate AS. And in those patients, obviously, it's very hard to figure out if their symptoms are from aortic stenosis or from HFpEF. And that was basically the premise of the trial. We don't know the results yet, but that'll be interesting. But at least in our practice for AR, we don't see those patients. We see them quite late. And it's not hard to figure out, what is the cause of their LV enlargement or LV, damage when they have such significant aortic regurgitation.
Sachin, thank you for a good presentation, and so thank you for all the great work you do in fixing the valves for our patients. I think the field of valve heart failure, as we call, I think it has become really prudent. And the VAD world, as you pointed out, I just wanted to share my experience on the complexity of this AI, because the patient that you showed was not that obvious symptomatically, right heart cath, but because of her exertional limitations, it was all functional limitation, we kind of made this decision to move forward, and she's done wonderfully, right? So some of these things, as Dipen pointed out, will rely on clinical acumen, alternative options, and then bite the bullet and do in certain cases. My question to you is, I'm glad it got approved yesterday, because we've had so many of these patients struggling for AI. The TAVR world has taught us that the enthusiasm of TAVR in AS patients now is being tempered down by valve failure. And it comes down to the question of, I feel there are some cases of TAVR that I've seen are done in patients who are technically moderate risk, but they could have gone through a surgery. But then on the back end, after 8 years, their valve fails, and now it becomes a higher surgery. So my question is, with that lessons learned, are the current valves, the Yenna valve and J valve, have any durability assessment compared to the structure of the TAVR valves? Because once you fix the valve, the durability will be the same issue, right?
That's a loaded question. So we could discuss this for a long time. But the short answer is, you're absolutely right. There has been, an indication creep, if you will, that has occurred, I think, in the TAVR field. Actually, Mike Reardon and I wrote an editorial in JAMA, which was titled Indication Creep. So you're absolutely right. There has been an indication creep, partly driven by, patient, desire to have a less invasive treatment option, partly driven by, our own enthusiasm to do less invasive procedures and grow the field. But be that as it may, we have to be cautious that none of these devices have long-term data in large groups of patients. For, the durability for Yenna valve and J valve, obviously we don't have long-term durability data. We have 2-year data on Yenna valve. But these patients will be followed out to 5 years for the high-risk patients and 10 years in the, intermediate-risk patients. For AS, again, the 6 and 7-year data, as you know, with Evolute and Sapien, when you look at the totality of data, look, comparable to surgery. There were some signals, as you know, that Mike Reardon presented, showing, slightly increased risk of reintervention with some of the older platforms of the older, Evolute platforms, in part related to, some of the techniques which are now obsolete and some of the other things. So long story short, yes, we have to be cautious. When we see these patients, we always discuss the lack of long-term data. These patients need to be closely followed. But also these valves and devices have gotten better. The techniques have gotten better. We've learned a lot more about how to implant these valves, how to, pre-dilate, how to post-dilate, how to optimize the result. So that is constantly evolving. Yes.
Yeah. No, I think that's great. I'm glad I saw your editorial, and I think this is something that we have to acknowledge as a field to temper down. Indication creep happens in every aspect of what we do. My other question is more of a system-based discussion, because I've seen this in the TAVR world also, and maybe Amit, Steve, or someone can comment. The spread of these interventions from specialized centers to the community is going to happen. And I've seen TAVR worlds where post-TAVR failures have been missed because in the community, busy practices doing 100 echoes a day, they're not paying attention sometimes. And I know the skill set of imagers and echo specific to these valves needs to be significant. So how do you protect that in the context of both decision making and also follow-ups in these? Because I feel like once you put in the valves, it's not easy to image these. And are there recommendations being driven specifically on what kind of imaging should be done versus not?
Again, great question. We see this, we have seen this, in the last 5-6 years. We were one TAVR site, I think, up until 2018. And then in the last 7 years, we've gone from one TAVR site to 5 TAVR sites in the system. So yeah, that is natural evolution, I think, of structural heart and TAVR programs. And, we are going to see more and more complex patients, coming here, patients in shock, patients with late stage valve dysfunction. And we are already seeing that right now. We have 3 patients on the service, as you know, who presented with shock, various kinds of shock, different valve disease. But the point is patients presenting late. So yes, there is, it is critically important that these patients are closely followed and monitored in the community by their respective valve clinics. Or if, and I think we all need to do a better job at education in terms of educating the echocardiographers and the general busy community cardiologists in looking for things. For example, a doubling of a gradient, for example, after a TAVR for aortic stenosis is not a benign thing. You need to look for halt. And if you miss that, that could be a precursor for early valve failure. So some of these things we have seen over the years can go missed or undetected, and patient presents late with heart failure and valve failure. So you're absolutely right. I think there has to be a system-wide approach to studying this systematically, educating providers, physicians, and ecotechs about valve degeneration.
Yeah, just a couple of comments on that. So the second point about the systematization of this and the rollout, absolutely right. I think every echo lab needs to recognize that structural valve deterioration is being seen more often, whether it's surgical or transcatheter. It's part of the gray wave. As this population grows, we're going to see more and more and more of this as a percentage of the imaging labs. We have to recognize it. I was going to say CMS has a big role here, though, right? I mean, we don't have the coverage determination yet for JenaValve. It just came out. So it's approved, but it doesn't have a payment model or indication about who uses it, because the current NCD for TAVR is very clearly for AS. So it's going to have to be modified, recreated, included for AI. So that's a big deal. The indication currently is only for high risk and symptomatic, which is a small window. So that's a sort of protection for the big rollout. But I heard, the ARTIST trial, which you're defining, if that's positive and it'll be influenced in practice, the lower end of the inclusion was asymptomatic and moderate to severe AR. That's a very different group. That's a much bigger catchment if you start including asymptomatic and not even severe. Now, yes, in the trial, they have to be randomized or willing to be randomized to surgery. But fast forward 5 years, if that's a positive trial and that gets rolled into an NCD, now you've got a very different threshold to put in a transcatheter valve in asymptomatic people with only 3+ AR. So those are very real issues that will happen. But the disease is out there and there's lots of it. And, the imaging is going to be critical, whether it's CMR or TE, or perhaps even, as you mentioned, CT. Everybody has to get better at this.
Absolutely.
Thank you very much, Dr. Goel, for a great talk, and I agree with everything that's been said, particularly for the grading or the quantitation of severity. It certainly seems very likely that there's different phenotypes and groups. The older patients, age is a very good surrogate for comorbidities and diastolic function or dysfunction. So when we looked at the older versus younger group in the MRI study, with regurgitation severity parameters that associate with outcomes, they were indeed actually significantly lower in older patients. So it's 40s for regurgitation volume versus 30s for older above 60 patients. And then for the remodeling criteria, that work was also kind of covered a little bit by Cleveland Clinic. They show the ESV thresholds, high 40s for young men versus 30s for older men and for women. So it's it's one of those things that we have to really be careful in looking at when we're reading these echoes and when we're seeing the patients. What I wanted to ask you was about the indication creep also, and then also a bit of a loaded question. We've seen the growth and the remarkable expansion of TAVR and AS. With AR, there's these two big groups. You have the 40 and the 50-year-olds with bicuspid valve, maybe aneurysms, prolapse. I mean, all of these are surgical cases, and I just wonder, will TAVR go through the same for AR? Will it go through the same pathway that it did for AS, or will it be 30-40% of patients that kind of get into the TAVR world, but the rest will just still be surgical disease?
You're absolutely right. I think TAVR for AR has to go through the same rigor that TAVR for AS is going through. I think the randomized trial ARTIST is looking at patients purely for that are going to get AVR. They're not including patients that are going to get a repair. They're not including patients who are going to get a Ross. They're not including patients who are going to get their ascending aortas replaced, for example. So if they have an indication for replacement of the ascending aorta, they're out of the study. This is purely aortic valve replacement, surgical or transcatheter. And, for bicuspids, as you know, there are two big randomized trials. For AS population, there are two big randomized trials that are sort of, on the cusp here. We will be participating in at least one of them that are going to be randomizing patients with bicuspid AS to surgery versus TAVR. So lots more to come. These are going to be, at least one of them is not an industry-sponsored trial, if that means anything. So there is a lot of interest and enthusiasm in studying this systematically in a very rigorous manner, in a disciplined manner, to figure out how to, how TAVR versus SAVR does in the bicuspid population. So there is a lot more to come, as you can imagine.
Okay, I'll take the prerogative. It's 9 o'clock. So thank you, Dr. Goel, for a fabulous presentation. He'll be available for more questions on Twitter, on X, on LinkedIn, and on the crosswalk. All right, thank you, everybody.
Thanks, Steve.